Then we'll have lab time on male. Okay, I'd like to get started on female too, since we missed. Still trying to catch up on missing Labor Day, but I don't want to lecture both of those. So we'll do male. Have a break in male lab. Oh my gosh. We have a quiz on that Wednesday.
You're so tall.
And then we'll come back and start on female, and I have a lecture note from my office.
Will today's lecture be included on the quiz on Wednesday?
The lab material, yeah.
Just for
So I do
male
have
or
your
female?
Okay.
Okay.
I have your female lecture notes in my office that I'll bring in, okay? So the first question, it's kind of a lab question. Identify this opening that you see right here. This would be in the connective tissue of the extra-abdominal oblique. It's forming both the wall and the opening in that. And continuing down is the external spermatic fascia. And I have your lab reports, one and Wednesday's lecture, so we'll get back to you. Okay? Got them up on slide. Anybody need more time? Okay, question number 2.
We already on 2?
I asked if anyone need more time.
Oh no, I'm thinking we were going to lecture. Never mind.
Okay. So question quiz 2, last week we asked about this one, the secondary spermatocyte. So today I'm asking about the primary spermatocyte. What's the chromosomal pattern for the primary spermatocyte? You're going to have this on the exam. Remember, you're going to have a table of different cells. I'll give you the choices as well for you to fill in. So usually about half the class is half those questions, and I want you to break that pattern.
Oh, yeah.
If it helps, ask yourself whether the primary spermatocyte is a haploid cell or a diploid cell. Okay? Work from there.
Right? And then it goes haploid. Right? I'm trying to find that. Is it okay with that? My notes are so jumbled. So she's going for the primary.
You'll notice we have fewer students. Our class has dropped from 35 to 27.
Oh, and then it's gonna drop down to 20.
Yeah, because actually it didn't last year. It stayed about 26.
I'm here for
Might
a
bother
long
you.
haul.
No, I can see my paper.
Oh, okay. Next question.
Works great for me. Well, it says 2
Similar,
too.
but using the slide. So identify the chromosomal pattern within this nucleus. So there's 1, 2, 3, 4 examples of that nucleus. So what cell has that nucleus? This is probably the best one right here, because these other ones aren't showing the nucleolus. So what is that cell? And then what would be its chromosomal pattern?
Oh, okay. Let me do that again.
You're looking at the nucleus, not the cell. This is the nucleus. Each of these circles is the nucleus of a cell. The dark component is the nucleus. So this is the nucleus of what cell? And what's the chromosomal pattern for that cell? So think of all the cells that we have in that area. From here to here. And which one has that nucleus?
And then I switched number 2. Yeah, do you guys get deeper? Switch secondary? No. Because it has the.
Well, I know, but you think
have it as the nucleus for the serotonin cell. If you're interested.
Yes.
Yeah.
Identify, it helps identify this cell, identify this cell,
So
this
like if you
cell,
look
this
at this
cell,
image
this
over
cell.
here, this big dark
Is there anything
one,
missing? And then work from
serotonin.
there.
I think it's
So you're saying it's
yeah.
the ST?
It would be a diploid.
Diploid.
ST. It's the ST. It wouldn't be S1 because it's more closer.
Oh, wait, no, that's.
I think it's 2N. 2N.
No, because S1, you see how it's like almost white?
No parentheses, right?
And then the two, like when you go to the sub-10,
Man, I see what somebody just totally
sub-10
stopped saying.
cells are also
Yeah, right.
subtotal. So it would be just 2N, it's just a regular diploid cell. And B, yeah, and then for number 2, according to her notes, the
Okay, we want more
primary
time on 3.
cells are,
A little bit more time and then draw a picture of that
2, it sees 2, yeah.
nucleus and we'll move
Because they're the
on.
tetra, right? So that's why they're 2.
15 minutes in the past, I'm yawning.
And number, don't listen to me. Talking out, thinking, it's okay.
Maybe not.
What?
Oh, yeah, sorry.
No,
It's my personal spotlight.
I know. You got a light for your nose, it's kind of awesome.
It automatically like place when I go.
So these questions interspersed throughout lecture should give you an idea. Some of them will be over material we just covered like 5 minutes ago, and some of them will be from the last lecture. Okay, so I'll give you a kind of, along with the assignments, an idea of if you're keeping up with your studies. Yeah.
Are these quiz questions similar to what the questions are gonna be like on the test and the final?
Yeah, the assignment questions are as well.
Okay,
Okay.
perfect.
All right,
She pointed to the
so
one
we've
with the
gone
one
through
with
the
the
glands. Let's just do a
With her
little bit
laser
of
pointer?
review.
Do something else.
So we started out with the testis. Is that a gland? Yeah. It's a endocrine organ, all right? So it's an endocrine gland. Testosterone and inhibin are going to go into the blood. Androgen binding hormone or protein is more like a paracrine. And then we have the seminal vesicle and the prostate gland and the bulbourethral glands. What type of glands are those? Do their secretions go into the blood, or do they have ducts?
Ducts.
Ducts. So we have the ejaculatory duct, we have the small multiple ducts for the prostate gland, and each bulbourethral gland has a duct that transports it into the urethra, so to a surface. So those are exocrine ducts. Okay, we're not going into the blood directly. And then we had the tubule system, so we had the seminiferous tubule to, this should be second nature now, so we have seminiferous tubules to straight tubules to beauty testis, to efferent ductules, so the mesonephros tubules, to epididymis, mesonephric duct, vas efferens, mesonephric duct, ejaculatory duct, mesonephric duct, and prostatic urethra. All of those are mesonephric duct, from the epididymis to the prostatic urethra. So now we're ready to start through the structure of the penis, and it can be a little bit difficult. A lot of diagrams just stick with this. It's like, okay, what am I looking at? This is the pubic angle, which you know in males is more acute. It's the issue of tuberosity, issue ramus, and inferior pubic radius. Along those set of rami, we have the attachment of the leg quote of the penis, the crease of the penis. These two structures here are known as the corpora cavernosa, and I have some diagrams from Netters that I'll show to you in just a moment. So when we identify the surfaces, and this is back to the relationship terms of Bio 430, when we talk about structures that are horizontal, we switch from the anterior, posterior, dorsal, ventral, which are interchangeable for the trunk of the body for humans, all right? So this is the ventral surface of my face. It's also anterior. Ventral surface of my abdomen, it's also anterior. Ventral surface of my palm, it's also anterior, all right? However, if you look at a four-legged animal, a deer, a dog, whatever, that have all four paws on the ground, anterior now is the head and posterior is the bottom or tail, okay? Then tummy, for me, is ventral for the dog. And my back instead of being posterior, is going to be dorsal. So anterior posterior is no longer interchangeable. And like my paw is horizontal. And so the top surface is dorsal to the bottom instead of being superior. So the penis is identified for surfaces as if it was erect. All right? So if it's hanging down like this, we're thinking of this as anterior and posterior. But if we name it as erect, then it becomes dorsal and ventral. Okay? So when we look at a cross-section of the penis, the vein and arteries and nerves that supply this are identified as the dorsal nerve of the penis, the dorsal artery of the penis, the dorsal veins of the penis. Okay? And that's why, because that is related to it as a horizontal surface. There's the small, not small, but a single ventral erectile tissue that's hard to see here. So I'm going to switch to Netter's, and this is a diagram from Netter's. The guy's on his back, his hips up as if he's getting an anal exam. Here are the two ischial tuberosities. And this is the set of diagrams we're going to use when we do the clay modeling, okay? Which I believe is Wednesday, so you need to bring your clay for that. So I'm going to diagram this on the board. I'm going to put in some components I'm going to erase because I'm going to cover up with erectile tissue, so you might want to wait unless you have a good eraser, because I'm going to draw it and then immediately erase it, okay? So here we have the pubic symphysis, the pubic angle, obturator foramen, ischial tuberosities, inferior pubic ramus, and ischial rami. Okay? So that's kind of what we're looking at here. And then as we move deep, we're taking off the skin and going in deep. We see muscle. This is skeletal muscle. We're going to add it on later because we're going to build it up. All right, we take that off. We see connective tissue. And now we see the erectile tissue, the three bodies, or corpora. So we have corpora for the, corpora for the capronosa and just corpus for the spongiosa. Corpus meaning just singular. So I'm going to draw the dorsal structure first. Okay, it starts lateral and attached to the ischial and pubic rami, we have the leg or crus of the penis. Crus refers to leg, we need to ankle. All right, but it's called the leg of the penis, or crus of the penis. And it's that component that's attached to the bone. Plural is crura. We're talking about both, okay? And I'll come back to what we mean by erectile tissue when we cover the physiology. Once it's no longer attached to the bone, it's called the corpus. And if we look at it in this more sagittal view, there's a shaft. So notice it's not attached to the pubic symphysis. There's a sheet of connective tissue that suspends it from that that's not being shown. But because I'm drawing it in an erect position, it's going to cover up that pubic symphysis. So now extending from the bone, and we're doing this in an erectile position. So these are the two corpus cavernosa, or together corpora. Okay? Making out what you would consider to be the shaft. Or plural is corpora. Okay? So remember last week I talked about we're going to cover structures that become something else. So I want you to know that back and forth. So the acrosome develops from a single Golgi cisternae. All right, the efferent ductules develop from the mesonephric tubules. All right. So in this sequence, the corpus cavernosum develops from the crus. Okay. So now we're going to look at this middle structure. And the bulb of the penis is supported by a muscle here that I'll draw in just a moment. It's the sphincter that you voluntarily relax or to contract to keep urine from leaving the body. And that's where the urethra actually enters into the penis is through the bulb. So I'm gonna draw that here,
What is that called?
the bulb of the penis. Okay, and then now I'm going to erase because it's ventral to these structures, so we don't see those structures. And developing from the bulb of the penis, we have the corpus spongiosum. It's going to be on the ventral surface of the penis. There's only one. So corpus spongiosum develops from the bulb, where the bulb becomes the corpus spongiosum. And then you can see the distal end of the corpus spongiosum expands to form this mushroom-like cap that passes ventrally to cover or dorsally rather, to cover the two corpora cavernosa. So I'm going to erase this. And we have the most sensitive region of the penis, which is the glans penis. Okay?
So the corpora spongiosum forms the glans penis?
Exactly right.
You know, this is a question on
Okay, so bulb develops into the corpus spongiosum, and corpus spongiosum develops into the glans penis. Now, remember I said that the urethra passes into the bulb? All right, so that's where it enters the penis. So we often talk about the penile urethra. The urethra has three parts. And penile urethra is that part that enters the bulb and stays within the corpus spongiosum and exits the glans penis. Another term for that urethra is the spongy urethra, because it's found within the corpus spongiosum. So if you call it the spongy urethra, that can help you remember that it's in the corpus spongiosum and not in the corpus cavernosum. Because for years when I was learning this in high school and college, I kept getting it looked like a cavern when you look at the opening to the urethra. So I kept wanting to call it the cavernous urethra. But that's related to the erectile tissue, okay? So it's going to enter the bulb and be found within the corpus spongiosum and then exit just on the slightly inferior aspect, ventral aspect rather, of the glans penis. So spongy or penile urethra. Now when we talk about female on Wednesday, because we won't get to it tonight, remember the embryo develops into a female phenotype unless the genes on the SRY gene is expressed on the Y chromosome. So the labia minor, those are the thin inner lips of the female that don't have hair follicles on either side of the opening of the vagina, they fuse in the male to form the shaft of the penis. If they don't fuse, there can be an opening along that ventral aspect, okay, completely or partly, or the opening to the glans, to the urethra may be a little bit more ventral than closer to the tip. It's not right at the very tip anyway, but it's slightly, but it's called hypospadias if that opening is too ventral. All right, so back to our diagram here. We have the crus of the penis becoming the corpus cavernosum. Crus is attached to the bone on either side. The corpora cavernosa is free from the bone. The bulb of the penis is attached to this underlying muscle that I'll draw in just a moment. Contains the origin of the penile urethra or spongy urethra. Then the bulb becomes the corpus spongiosum, and the corpus spongiosum expands to become the glans. All right. Now the skin of the shaft of the penis is going to separate and pull back on itself to form a foreskin, or the more layman's term, well, the foreskin is saying this term, prepuce is the anatomical term, okay? So when a baby or a boy or a man is circumcised, it's that prepuce that is removed to expose the glands. If it's not removed, the child has to be taught to retract it, pull it back, and to clean around the glands, all right? About 15 years ago, San Francisco banned circumcision within its city limits. That only lasted for a short time because a lot of cultural groups do it. They were concerned kind of like female circumcision as body mutilation. It's not needed. Some guys say that sex feels better with it. Most people that are circumcised between 7 and 12 days of age, so they have no idea whether it feels better or not.
Or a couple of hours.
Pardon?
Or a couple of hours.
Yeah. Well, when I started working OB, parent moms and babies stayed for 3 days, and the OBGYN would do it about the day after it was born, and it'd have a day or two to heal before they went home. Now that moms go home within 20 to 24 hours, it's usually the pediatrician that does it in his office, so it kind of varies. So when my son was circumcised, my oldest son, he was born on, like 7, and we left at 10 the next day. And so the pediatrician came by to visit me and said, "Do you want your child circumcised?" And I said, "Yes." And so he said, "Come by the office in 7 days," which is the Jewish standard. And we'll talk about why, because it's the level of clotting factors are reached their maximum at that time. And so I'd helped in literally hundreds of circumcisions when I worked as a labor delivery postpartum, worked in the nursery, and we had what's called a circuit board, and with Velcro straps, and then we strap the baby down, and he would scream his head off, but usually be asleep by the time the doctor showed up. And there's various contraptions. The most common is called a Gomco clamp. It's a steel ring, stainless steel ring that can be circumcised, and they'll place that over the baby's penis, retract the foreskin over it, and then screw down the top really, really tight, which cuts off all the circulation, and then a quick swipe of the knife and you've got a donut of skin. And then unscrew it and sprinkle a clotting coagulant, and then wrap some medicated Vaseline gauze around it, and every time the diaper's changed, that's changed as well. So that's what I was expecting when I went in. It's only been 4 or 5 years since I worked as an OB nurse helping with that. And so circuit board's there on the counter, and the doctor, the pediatrician, gets out a knife, gets out a syringe, and right at the base of the penis on each side, he injected a local anesthetic. And then he really screamed. And I said, "I've never seen that before." And he said, "Well, studies show that they do feel pain." I was like, "Yeah, now that you put that syringe needle in them." And it was very different having my own child circumcised. So I'm sitting beside him, he's right here, and I'm holding on to one of his big toes, and my husband's facing me. Their knees are touching. It's like, I can't even look at my husband, because I know if I do, I'm gonna burst into tears. So when it came time for our second son, I just handed him to the nurse and said, "Bring him back when he's done. I don't need to be there." I thought I would be fine. But anyway, so the Journal of,
Same thing, my first.
what was it? Journal of, I forget the Journal for the Male Health. But they're saying, okay, this doesn't need to be done. There's no health factors for the guys, and it's perfectly true. But about 2 months after that, the Journal of Obstetrics and Gynecology came out and said, well, it may not make any difference to the guys, but women are more likely to get cervical cancer if they have intercourse with men who aren't circumcised. It has nothing to do with the prepuce. It has to do with the bacteria and other material that might be trapped between the glans, penis, and the skin. So, my babysitter's son was circumcised at the age of 5. That must have been fun. I'm sure they put him under under general. And then some guys decide, at whatever age, once they're adults, to be circumcised. So on Wednesday, we'll talk about female circumcision, which most of you have probably heard of by now, and it's completely different. The female has a prepuce, but in essence, what's being removed from the female It's not just the prepuce, but all of this. Okay, so all of the sensory aspect and most of the rectal tissue. So we'll talk about that part aspect when we get to it. So let's look at the muscle now that we associate with the penis. The urethra passes through a muscle that fills in this triangle of space. Okay? I'm just gonna put a number there rather than write the name of it. So this muscle is the voluntary sphincter around the urethra. So if we go back to this image, it's this muscle right here. Some of our models, it's white instead of red, but it goes from the pubic angle at the top, about partway down, just anterior to the opening to the rectum. Okay? So when it squeezes with voluntary control, it's going to constrict the flow of urine or sperm through the urethra right there. It's the most narrow region of the urethra. Okay, so if a guy's getting catheterized, that's the most difficult part to get the catheter through. Remember I said there's 3 parts to the urethra? So now we've talked about all 3. The first part is prostatic, where it's passing through the prostate. Second part is membranous, where it passes through the sphincter, and the rest of it is the spongy or penile. Okay? So different names, we call this the external urethral sphincter. The internal is smooth muscle. So this is the one that doesn't work. Maybe it works all the time for you guys, but when I was in high school, I never used the bathroom after I left the house until I got home again. So from 7:30 to about 5 in the afternoon. I used the bathrooms at the school, the high school, to brush my hair, and that was it. Okay? The house that I'm staying at now, I'm renting a room from a friend of mine, I can hear in the bathroom, I can hear people talking in the kitchen, which is around the corner. So if there's someone in the living room, which is like 8 feet away, I'm sitting there going, ding, ding, ding. This is not going to work because I can hear you talking. If you can hear me talking, you can hear me tinkling, and it's just not going to work. So that psychological inhibition not working is because this is voluntary. You have to be able to stop that to allow it to dilate. Okay? So this is voluntary muscle. It's also known as, AKA, its scientific name is deep transverse peronei or perineal muscle. And there is a superficial one that's just very narrow column right here. Okay? You don't have to know that one, but that's why it's called the deep one. Because this is the superficial one right here.
So according to the notes, we shouldn't call it the deep perineal, we should just call it the
What's named transverse perineal? Because there's 2 transverse ones. But then the other name is the urogenital diaphragm. Okay? This is innervated by the same nerve, branches of it, that innervate the floor of the pelvis. So you may not have covered those in 430, but I'm talking about the levator ani, so pubococcygeus, puborectalis issue. Anybody know what nerve that is? So in lab today, you can actually see it on this model. It comes out the greater sciatic notch with the sciatic nerve. It goes back through the lesser sciatic notch, pudendal nerve. Okay? It's going to give branches that are called superficial perineal and deep perineal and dorsal nerve of the penis. But as far as we're concerned, you just have to know pudendal nerve for that. You don't have to know the perineal branch. Okay? So that's voluntary skeletal muscle. Perineal nerve. Sorry, this is not perineal. Pudendal. I'm telling you, you didn't know it. It was on my brain. Okay. All right.
Okay, real quick, I'm
Yeah.
sorry. Can you point to one on this picture? Cause this picture is what we have,
This picture doesn't show the nerve on it, but let me,
not the nerve, no.
oh, the muscle?
The
You
one,
can't, it's behind this connective
behind
tissue.
that, okay.
Yeah,
that's
behind that
it.
connective tissue. We, in Bio 430, we saw it in the female, because our models are of the female, when we were learning elevator ANI and so on.
So will that be on the lab, exam?
So, yeah, it's deep to that, so I said, what muscles located here? It's not shown in any of the superficial one is there, but the deep one is
Yeah, that's what I was like,
the deep one's not there.
okay.
Okay? All right, then we have two other muscles that are involved in ejaculation. So these provide the greatest force for ejaculation, although other muscles are being used. Yes?
I just wanted to ask what name you prefer for that.
Pudendal is all you need to know. We're not gonna learn the perineal, superficial, or deep perineal branch. Okay? All right. This covers the crus of the cavernosa, of the crus of the penis, which is becoming the corpus cavernosum, and it's attached to the ischial bone and part of the pubic bone, which gives rise to its name. So that muscle is called the ischiocavernosus muscle. Okay? I'm just going to draw it in on one side. We're going to model this on Wednesday. So that's the ischiocavernosus muscle. And it's also, it's also skeletal. Also innervated by the pudendal nerve. Okay, so on both sides, covering the crus, is ischiocavernosus muscle. And then, this is split down the middle, because it's two separate muscles. We call this a raphe. So we had a raphe with the mylohyoid. We have a raphe between the cheek muscle and our pharynx muscle, so where they share a common connective tissue point of attachment, like a seam line. So that's called the bulbospongiosus muscle. Covers the bulb and part of the corpus spongiosum. So I'll draw it on this side, but it is on both sides. Okay. Goes partway up the shaft there. That's also skeletal muscle, voluntary, innervated by the pudendal nerve as well. And when we talk about ejaculation, in a little bit, the pudendal nerve is the one that innervates it, so we're going to be diagramming that on the board. Yeah.
You said this was an ejaculation muscle?
Uh-huh.
What was the other, the external urethral sphincter?
That one is